The plenary one, the first session of our Congress. It's entitled Asia Pacific and Personalized Medicine, Predictive, Preventive, Participatory, Personalized, and Pre-emptive, 5 Ps, of course, health systems in Asia Pacific. So now we would like to invite on the stage our moderator, Kun Einstein Rojas, board member of the PAPO, the Philippines Alliance of Patient Organizations. And then our speakers for this plenary one is Kun Kawaldip, Sehmi, our CEO of the International Alliance of Patients Organizations, IAPO. Kun Farid, Bidgoli, General Manager, Roche, Thailand, Myanmar, Cambodia, and Laos. And then Dr. Arshiya, Zaheer, Regional Patient Engagement Lead, Japan, China, and Asia Pacific MSD. And then finally we have Dr. Ugyen Tshomo, Obstetrician-gynecologist and co-founder and board member of Bhutan Cancer Society.
And you can find the speakers' full biographies on the 4th Asia Pacific Patients Congress page on IAPO's website.
Yes, and then as we're getting ready, before we get started, we invite everyone to submit questions to the speakers, whether you're attending in person or online. And online attendees, you can send your questions via the Q&A tab by the virtual stage.
And now we would like to invite our moderator to take the floor.
There is like a microphone? Oh, already. Excuse me. It's a bit steep. Thank you. Thank you.
So good morning, everyone. The first session is about Asia Pacific and personalized medicine. Predictive, preventive, participatory, personalized, and preemptive. 5 Ps, health systems in Asia Pacific. This session looks at genomic medicine and its various applications within the Asia Pacific health systems. The terminology currently used needs to be standardized in the Asia Pacific region so that we all are talking about the same health technology and applications. We now have an innovative health technologies at our disposals that can help our health systems to become predictive, preventive, participatory, personalized, and preemptive. These 5 Ps within the Asia Pacific region can improve patient health outcomes, patient experience, meet and matching patient preferences, health systems, effectiveness, efficiency, safety, acceptability, and accessibility, whilst delivering quality healthcare in a compassionate and humanistic way. These health technologies have their greatest application in NCD control and care. We can transform and personalize the way in which and how fast NCDs are screened, diagnosed, and treated without disrupting lives and families. Personalized medicine aims to give the right treatment to the right patient at the right time. This gives us better outcomes and improves patient safety, particularly reducing the risk of adverse events. And now I would like to welcome our first speaker. We will talk about the importance need for the health systems to be 5 Ps. Please welcome Kawaldip Sehmi, the CEO, International of Alliance of Patients Organizations.
Okay, thank you. Einstein by name and Einstein by Nature, because when we spoke about genomic medicine, he really took it to heart. I'll be brief. I will try to tell you what this means to me as a patient. What would predictive, preventative, participatory, personalized, and preemptive medicine could have meant to me. I, as a colorectal cancer patient, was diagnosed late, and then what followed on was a series of difficult diagnoses and challenges, but went through those successfully. But when you come out of the end of it, you realize that it could have been better, and that's better I'm bringing to you. Firstly, health systems must know that we can work differently. We don't wait for disease to happen. We don't wait for the pandemic to unfold upon us. We could have found out about the pandemic months earlier. You know, when it was pretty, we could have found out where is this virus moving. We could have predicted the movement of the virus. We could have picked out where the breast cancer cases are happening. We could have predicted which populations are more inclined to certain conditions other than not. We can be predictive, so don't wait for things to happen. Predict where they are. It's almost like a military tactic. You don't wait for the enemy to attack you. Anticipate where the enemy will come, and then choose your battlefield and choose your higher ground. Very important, the 5 Ps have to be there. Then preventative, again, goes without saying. Don't deal for patient to get ill. Don't wait for me, like my case, for the cancer to develop. Let's deal with it early, excise it quickly, or treat it with appropriate monoclonal antibodies or any other immunotherapy quickly. And lastly, be participatory. Let's work together. Don't work in ivory towers. And lastly, let's personalize it. I needed special attention, and that should have been addressed to me. And women with BRCA1, BRCA2 gene need something personalized. Younger patients need more personalization. So the way to go forward is personalized medicine, because it is good for us, for the outcomes they bring in, but also the way we can segregate our population is good for the economic system, UHC, because you save a lot of money by not giving the same treatment to 100,000 people when you know you could have done it for just 50,000 and got good results. We look at the system that's going on at the moment and look at what our Personalized Cancer Care Alliance is working on. We have a Personal Cancer Care Alliance that's looking at 5 Ps as its main topic, and it's very important for us that we drive this forward. And we know that the health system is a complicated arrangement of institutions, scientific evidence, and I would say to some degree even political interests. And somebody's health is a political choice, and you know that we have to work through this political choice by making sure everybody is engaged. There are a lot of people there with very sensitive skins, you know, who get upset by things. And a lot of people who don't want to see or come on board quickly on change when it happens. We've got to bring them all. We must bring in responsiveness, we must bring in fairness, and we must bring in other responsibilities so that people can be treated fairly, decently, and humanistically, and scientifically appropriately. Again, people-centered healthcare or integrated healthcare services of WHO is a complicated map of issues, but remember, I always say this, when you are dealing with a patient or any human being, irrespective, how would you be like to dealt with? Deal that way. The rule is deal with that as if you're dealing with yourself. Once you get that right, my grandfather used to say, when we were very nasty, we were not fair to other children around the area, he says, deal with every person as if it's your mother. How would you deal with your mother? You'll deal compassionately, you'll deal understandingly, you'll deal fairly. And I used to say I deal with her with fear. So humbleness and fear, very important for us. Let's deal with them. And our work, as I said, will not complicated. Please go online. You'll find that personalized cancer care, how we work. We're looking at how genomic and digital healthcare can be associated. We are bringing in personalization. We are bringing in technologies that can work for us. We are bringing in people, and we are looking at other aspects of our healthcare and ensuring that we have access to all that new innovation. We are building bridges between the academic institutions, the geneticists at the front, public health expertise, and others. And again, the alliance is now up and running. We hope you can join us when you've got time to work with us. We would like to bring in as many people as possible in the region. We have started up in WHO AMRO, Eastern Mediterranean Region Office at the moment, with the hope that it builds up a good balance, because the region is very interesting. On the right-hand side, we have got the Gulf Cooperation Councils, who are money rich at the moment. Energy prices have shot up. Their revenues are increased. They don't know what to do with that kind of cash lying around. So we are saying invest in Personalized Cancer Care Alliance. And then on the left of the region, we have got conflict-ridden areas that could benefit from this. Again, learn more from well-functioning healthcare systems if rightly impeded, if you get the 5 Ps into it. It's a way of working through and bringing us together. Again, as I said, these are things that are now developing. We are all moving away in what is called post-pandemic preparedness, as I call it. Let's make systems that are really efficient and work with us. Again, we said predictive is important, and that we must predict that. You can access most of this information online. It's an easy to follow pattern. Make sure that you access on them. The detail is there, again, what preventative is. We don't need to go into length about describing everything at every stage, but that's where we are, that we're looking at preventative nature of things, because we have said that 50% of health budget should be spent on prevention and prediction, and then the rest 50 you can spend on the late stage diagnosis on things that we couldn't deal with and acute healthcare. Participatory, we must be in the heart of this. And with that, I will say that thank you very much. And please come to me during the break. Let's talk, and let's see how we can set up an alliance in this region. Thank you very much.
Thank you very much, Kawaldip Sehmi. I also would like to invite the speakers, Farid Bidgoli, General Manager of Roche, Thailand, to join us in stage, as well as Dr. Arshiya Zaheer, Regional Patient Engagement Lead of MSD, and also Dr. Ugyen Tshomo, Obstetrician-gynecologist and co-founder and board member of Bhutan Cancer Society. For our next speaker, we will be talking about personalized healthcare through the industry perspective, application of personalized healthcare approaches in NCDs. Please welcome Farid Bidgoli, General Manager, Roche, Thailand, Myanmar, Cambodia, and Laos.
Good morning, ladies and gentlemen, and welcome to Bangkok. I've been calling Thailand my home for the past 3 years, so for those of you that are visiting, welcome, and I hope you have an enjoyable stay. I would like to first say that it's a great honor to be speaking to you today. I speak quite a lot, and I must say that when I was asked by the International Association of Patient Organizations to speak today, it was a really proud moment. Because every day I wake up thinking, how can I improve, together with my team, together with my colleagues, how can we improve better outcomes for patients here in Thailand, Myanmar, Cambodia, and Laos, and how can I contribute to a better society? So it's a personal thanks that you invite me here today. So today, I'd like to talk to you leading on from the conversation around the 5 Ps. And my name is Farid Bidgoli, and Farid in Arabic means unique. But the reality is that we're all unique. So why do healthcare systems treat us all the same? And how can we therefore demand that we have more personalized services when it comes to our treatment, our choices, and the way that we access healthcare? When we think about predictive healthcare, one of the best examples I can give you is in lung cancer. In fact, 12 years ago, we used to believe that cancer was the disease of this cell. Today, we know that cancer is the disease of our genome, our genes. And in fact, in lung cancer, today, we know that actually there are over 15 types of different genetic mutations, meaning there are 15 different types of lung cancers that we can hopefully treat now and in the future. And what we see is a growing trend in Asia-Pacific in terms of the use of biomarkers and comprehensive genomic profiling to really help treat different types of cancers, which is great news for us and for patients. So, if you get the right diagnosis and the right patient, the next most important thing is at the right time. And you alluded to this. And if we take lung cancer again, what you will see in Thailand is that 80% of patients here in Thailand are diagnosed with stage 3 or stage 4 cancer, which is a really late stage to be diagnosed where you have worse outcomes here in Thailand. And in fact, I was looking at data in Asia in preparation for the talk, and it's not too dissimilar. Taiwan is very similar. In Indonesia, it's very similar. So making sure that we diagnose patients at the right time is really important. And I want to kind of share with you how having the right diagnosis using biomarkers and comprehensive genomic profiling and at the right time leads to better outcomes for patients. So, when patients are diagnosed with lung cancer without any comprehensive genomic profiling, without any biomarker test at a late stage and given chemotherapy, then 50% of people will die at 9 months. It's not a great outcome for patients with lung cancer. However, if we use cancer immunotherapy, more advanced treatments, then we can extend life for a further 3 months. Doesn't sound great, really. It's not a great treatment outcome. However, when we throw a biomarker in, and we do a biomarker test, we identify patients who are PD-L1 high, and then give them cancer immunotherapy, for those same patients who could survive 9 months, we take their survival to 22 months. Now, as a grandson who's lost two grandparents to lung cancer, that's a far better outcome that I can sign up to. But like Kawaldip, I wish that people were diagnosed earlier, and this is where we need to shift, because when we diagnose patients much earlier, between stage 2 and stage 3 lung cancer, when we give them a biomarker test and when we give them the right treatment, 50% of patients will be still surviving after 3 years. Now, I think that's an outcome that we can all fight for and that's worth fighting for. However, ideally, we want to prevent disease. And when we look across cancers, one of the most preventable cancers that we have actually is cervical cancer in women. Cervical cancer across Asia is the 4th most common cancer in Asia. In fact, 200,000 women every year die from cervical cancer. Now, one of the biggest issues is actually to access to screening. And what we find here in Thailand is that actually women with busy lives, with low health literacy, don't access screening services for HPV, for cervical cancer. So what we tried to do then was to use different technology, a simple self-swab to help do a HPV swab. And we took this to factory workers here in Thailand, here in Bangkok. And actually, doctors and society said, no, 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 you can't trust patients to take the swabs themselves. They'll do an inaccurate test. And we heard this before with COVID. But irrespective, we did it. And 242 women self-swabbed themselves whilst they were at work. And out of those 242 swabs that were taken, only 6 came back inaccurate. And in fact, 18 women found that they had HPV virus and now are under further investigation. In the southern provinces in Thailand, there's a high Muslim population. So actually another barrier to accessing screening services is our religious beliefs or our religious preferences. And therefore Muslim women weren't accessing HPV screening. So we thought, well, let's try and repeat the trick. Let's see if Muslim women want to self-swab. And they did. And the results are very similar. And now in the southern provinces, we're taking it one step further in the fact that actually what we want to do is to deliver the swab to a patient's home. So they can order the swab test online, they can swab in their home, and it gives them greater accessibility and therefore to preventive care for cervical cancer. So also we need to consider how we use technologies in different ways to prevent cancer in the future. And that brings us on to the fact that we see the trend to patients, to people wanting more personalised services. And during the COVID pandemic, Accenture did a study. And they looked at actually what preferences were around people in terms of where they wanted to receive treatment. 58% of patients said that they would prefer to receive treatment outside of a hospital setting. And when we asked doctors and nurses the same question, they said that they believed that people are more interested in having services and care delivered at home. And in fact, that's what we're starting to see now with cancer services. So for women with breast cancer in Singapore, you can now get breast cancer treatment in the comfort of your own home. And in fact, I'm really proud that together with the National Cancer Institute, this month we launched a project here in Thailand to try out the exact pathway. So instead of women having to travel in the Bangkok traffic or 3 hours from some of the remote provinces here in Thailand to receive a 4-hour infusion, then now we're able to take a 5-minute subcutaneous injection into a patient's home, which is far more convenient for them. And it gives them choice. Some people would like to go to hospital, but some people want that convenience to have them receive care in their own home. So by harnessing technology differently, we can really personalize the way that people and women access treatments. We talked about participatory in terms of shared decision-making, in terms of being involved in decision-making for your own care, in terms of co-creating services and pathways. However, one of the things that we recognize in industry that we do really badly, or we've done really terribly historically, is that our clinical trials don't always include and represent the patients that they serve. So as industry, I believe that now we're really trying to change that and make sure that our clinical trials are accessible and include people of different populations and different ethnicities. And the Singaporean government actually, in 2016, recognized that for patients who had a comprehensive genomic profile or genetic screen test and who could access personalized therapies, actually when there wasn't a treatment option available, only 8% of patients got offered a clinical trial. So the Singaporean government have partnered with Roche, whereby now, using one of our services called Foundation Medicine, we screen people comprehensively to try and get the right diagnosis at the right time, to hopefully find the right treatment for them. But when there's not a treatment that exists, then actually our service helps doctors understand where there might be a clinical trial with an investigational medicine to help patients, so that we hope that more than 8% of people without a therapy to support them can access clinical trials. So participation in clinical trials and having more diverse populations is something that industry is really trying to move forward and fight for. And finally, preemptive. Wouldn't it be great if we knew about disease and knew about deterioration of disease before it happened? Well, in ophthalmology and neuroscience at Roche, we're trying to do exactly that with digital biomarkers. So in ophthalmology, for example, we've developed an application called My Vision Track, which uses gamification, whereby every day we ask somebody with neuromolecular, AMD, age molecular degeneration, or diabetic molecular edema, to go on every day and play a simple game. And over time, using digital biomarkers, before a patient realizes, we're able to realize when there may be deterioration in their visual acuity, when their eyesight might be getting worse. And here in Thailand, we're using a device called Sight Plus that is used to help patients with visual acuity, and again to test the same thing. In real time, can we understand and preempt when people are losing their eyesight, when their eyesight is getting worse? And if we can do that, then we have different options for patients. They can maybe have a different dose of treatment. Maybe they can have a different treatment. Maybe they can go to their doctor and understand what other therapies or treatment options are available for them to help them with their eyesight. And finally, in multiple sclerosis, a disease that's highly prevalent, not in Asia, but mainly in the rest of the world, we know very little about. We know little about why people have attacks. And therefore, we've got now the largest global open trial in the world by using digital applications and wearables to understand how in the life of patients with MS, how they're sleeping, how they're walking, how they're balancing, what their mental health status is, so we can really understand more about the disease. So digital biomarkers will help us also be preemptive around disease and help us understand more disease. So I've hopefully shared with you how industry and here at Roche, we're approaching the 5 Ps. What I would say to you is the future is already here, it's just not evenly distributed yet. Cap con cap.
Thank you very much, Farid, Bidgoli, for a comprehensive overview of the industries on Roche. Next, I would like to invite and talk about MSD's work on personalized cancer care. Dr. Arshiya Zaheer, the Regional Patient Engagement Lead for Japan, China, and Asia Pacific of MSD.
Thank you so much, Einstein and Swadika. I can't tell you what a privilege and honor it is to be back in a room interacting with people after the 2 years that we've had. So very honored and privileged to be here in front of all of you in Bangkok. And I'm looking forward to the next 2 days where we can not just hear from each other, but also engage with each other and learn about how we can build back better, as Kawaldip mentioned, and the work we all are doing. As a representative of the industry, we feel very much a part of the journey because, like all of you, we are either future patients or patients as well as caregivers. So we're very involved in the process of enhancing patient engagement. With that, I'd like to go on to my first slide. And I know this is a very basic slide, but it's really important to understand the evolution of personalized medicine. Where did we start from? We had the traditional medicine, and being a doctor who trained 20 years ago, that's what we were taught, a one-size-fits-all model. And then slowly it went into a stratified formula, which was more based on the different aspects of identifying genetic information, risk factors, and disease types. And now we have come to the era of personalized medicine, where we look at a customized, tailor-made approach when it comes to individual patients, looking at biomarkers and testing to predict, to diagnose, as well as to look at prognosis of patients for the future. And I think this is the way we look at the future and where we would all, as individuals, like to be treated. When we talk about us as an organization, MSD, which is known as Merck, we have a bit of a dual personality here. But we have a couple of global commitments when it comes to enhancing, advancing personalized medicine, specifically when it comes to personalized cancer care. We are part of the Alliance to Advance Patient-Centric Cancer Care in the US. This has been a 5-year-long commitment that we've been a part of. We're also a part of the Personalized Medicine Coalition, which is an alliance of innovators, scientists, patients, payers, providers, as well as industry, who are focused on understanding and adoption of personalized medicine concepts, services, and products, not only just to benefit patients, but also to benefit health systems. As an innovative organization, we're very proud to recently announce the joint development and commercialization of a personalized cancer vaccine with Moderna. And the last 2 years of the pandemic have truly shown us the potential of RNA technology and what we can possibly do. And these are very exciting times for us as we see the next couple of years, especially with the ongoing trial that we have. Apart from this, what do we do at a local level? We have a three-pronged approach when it comes to personalized oncology care. We look at working with scientific leaders, key opinion leaders, to talk about the advancement and better understanding of personalized medicine. We work with pathology associations and organizations at a local level to work with them to promote an understanding of the importance of biomarkers and their relevance. And finally, we look at data gaps. There are a lot of data gaps, and the potential of real-world data also comes in the space of personalized medicine. I think Farid, my colleague, mentioned that it's really important for us to look at clinical trials differently to ensure that they have a representative of the true population that we serve. So I think those are also some ongoing commitments. I'd like to spend a couple of minutes on Personalized Cancer Care Alliance, something that Kawaldip alluded to. And this is a prime example of how industry came together with IAPO to create a coalition of like-minded stakeholders in the Middle East and North Africa. This was initiated this year with PharmaMia, which is the industry association of the Middle East and North Africa, where MSD is leading the working group, along with other industry partners and IAPO. And the whole objective of this alliance was a four-pronged aim. The first one is to create a coalition, and I think Kawaldip showed the logo of the Personal Cancer Care Alliance that has come together. Secondly is to drive education and health literacy, and this was done through a series of webinars, again optimizing technology that we've all learned during the pandemic. And then finally, creation of advocacy tools. And what you can see on the slide is a draft of the white paper, which hopefully will be published by the end of the year. And all of this will ensure that the patient participation and the patient advocacy participation is built and focused on personalized medicine and cancer care. So with this four-pronged approach, through the last year, we have been able to create a framework which is not just recognized in the region, but as Kawaldip mentioned, even the WHO is recognizing this as an effective way where we can come together as like-minded partners to look at an area of focus for us. And why does personalized medicine and personalized cancer care matter? For us as industry, especially when we look at innovative drug discovery, it's really important for us to focus on optimizing the clinical benefits of our drugs, as well as reducing the risks, to ensure that we are meeting the patient needs, as well as meeting and matching what patient preferences are, not just physician preferences. And equally important it is for patients, because it is allowing them to get the right drug at the right time for the right patient. It allows us to also look at patient outcomes, and not just clinical outcomes, but quality of life outcomes. And eventually, by doing this, we hope to reduce side effects, which can be a huge area of concern for patients, as well as improve the patient experience, especially when it comes to cancer. By doing this, we will not only improve healthcare outcomes, but we will have better utilization of health systems. I'd like to end with this slide. The promise of personalized medicine, as you can see on this slide, has really not lived up to its potential. And maybe one of the reasons why is that we have not been able to engage a very important stakeholder, and that's patients and patient groups. I think we all need to come together to create awareness, better education, to build tools and research, and eventually alliances where we can work together to empower true personalized medicine. I'd like to end with a quote by William Osler from 1914, and though it's really old, it is very important for us to understand. A good physician treats the disease. A great physician treats the patient who has the disease. And according to me, that's the true potential of personalized medicine. Thank you so much.
It seems that we also have to end with a quote for our speech. Thank you very much, Dr. Arshiya Zaheer, and of course, for the industry's perspective. For our next speaker, we will be looking at the patient perspective, approaches to compassionate and personalized cancer care in remote communities in Bhutan. We'll also be talking about the patient care journey in remote communities. I would like to invite this to the stage Dr. Ugyen Tshomo, obstetrician-gynecologist and co-founder and board member of Bhutan Cancer Society.
I saw. Thank you, IAPO and APPC and Heart to Heart Foundation for inviting me to this Congress. So most of you may not even know where Bhutan is. Not moving. No, it's gone too much. Can you go back? It's a small country with a small population, and we have very difficult terrain with very difficult road system. So to get to even a 15-kilometer away place, you take about an hour. And besides that, we have low literacy. So in the villages, they'll first seek traditional care. They'll go to the spiritual leaders and all these people, and they turn to the modern medicine as the last resort. So we have a primary health care system where 90% of people live within 1 hour of a health center. So despite that, a cancer patient takes about weeks, sometimes months, to reach to the right place and get the right diagnosis. So you can see the topography of our country. So most of the villages are situated high up in the mountains with the main highways running along fast flowing rivers at the valley bottom, and it's very scary. If you fall into the river, and your bodies may not even be found. So there are places where we can go only by helicopter or walk for days to reach the nearest road point. So there, the only way to bring patients is by helicopter. So recently there was a movie made in this place which was nominated for Oscar. So looking at the cancer services in Bhutan, healthcare is completely free in Bhutan. Health and education is completely free in Bhutan, even when the patients have to go out for treatment. But the sad thing is, because of the distances and scattered population, we cannot have specialized services everywhere. So only 3 hospitals across the country has CT, MRI and pathologic services. So that's why a patient takes a long time to get his or her diagnosis. So where I work, I'm a practicing gynecologist. So I do, where I work, we do surgery and chemotherapy. But those that need radiation, they have to go out to India, and nearest place for us is Kolkata. The other thing is, when people undergo treatment for cancer, they have to stay in a place for a long time, and that puts a financial burden. It strains their financial conditions. And the other thing is, home-based palliative care is available only in the capital. So many patients who are dying and who are afraid that they will not get services will also stay in Thimphu. So despite having free healthcare services where cancer treatment, any treatment is completely free, the patient and families still need support and care. So that is why this NGO, Bhutan Cancer Society, was established by me as an oncologist, by our present health minister who had her mother and grandmother die of cancer. So she thought, despite having free treatment, there are other things that patients and their family need. So on 4th February 2016, with our Princess Arshiya Wangchuk as royal patron, Bhutan Cancer Society was established. So this is the picture of, on the left is the picture of the princess, and on the right is us receiving the certificate. So who are the beneficiaries? Our patients mostly coming from rural population. So 62% of Bhutanese population is rural. So all those people coming from far off places and their caregivers are the beneficiaries. So they need financial support for treatment while they are undergoing treatment or while they are undergoing follow-up. Many people need place to stay and also financial support during their stay. So it takes 4-5 months to stay in a place for cancer treatment. And then many patients, they need navigation. They don't know where to go, which doctor to see, and when to see. So this is all done by the Cancer Society staff who works as an alliance between the hospital and patients. So this is a patient guest house that was originally built, given to us by the royal patron, our royal patron Arshiya. And here the patients that undergo dialysis and cancer treatment and palliative, many of those that cannot afford to rent their own place also stay in this guest house in Thimphu. And we also have similar guest house in other hospitals where the patients can stay and undergo treatment. And our king also keeps a guest house in Kolkata for patients who are undergoing radiation, so that they don't have problem in a foreign country. And our care also goes beyond death. So these little girls, they lost their mother to cervical cancer, and we had to keep them in this guest house and look after them till they were adopted. And we are happy that they are fine just now. So apart from taking care of patients, we also do raise awareness on different cancers. The Ministry of Health gives free services, but they do not have all this time and resources to go for awareness and prevention activities. Of course, we have cervical, breast cancer and stomach cancer prevention activities, but not for all cancers. So we look at our cancer registry data to see what cancers are common from which districts, and then we go and hold awareness campaigns in those districts. So on the left is the awareness campaign for stomach and esophageal cancers, which are very common in Western Bhutan. And on the right is the head and neck cancer awareness, which is more common along the Indian border in the south. So these are some donors, and then when we hold our awareness fundraising activities and cancer awareness days, we always call our survivors. So these are some of us with the cancer survivors. So these are cervical cancer prevention activities, which is also run by, which is complemented by Cancer Society. The Ministry of Health has a horizontal program going on, but off and on, we in Cancer Society also hold camps in rural areas. So another place on breast and cervical cancer prevention. So these are patients that I see when I go for prevention activities. So patients who are, wherever they are, we keep in touch and they come to see me instead of traveling all the way to Thimphu. So patients coming for follow-up. So when they come for follow-up, many of them are helped by our Cancer Society staff. So in fact, they stay with us during our follow-up of patients, and they create WeChat groups and add them so that these people will seek care when they need. So not all patients are old. We have young ovarian cancer patients and very small children that have leukemias undergoing treatment in Kolkata. So this was when I visited Kolkata in 2017. Of course, we do not have medical oncologists or hemato-oncologists or pediatric oncologists, or of course, we don't even have radiation oncologists. So many of our patients, they go to Kolkata, and this is where we in Cancer Society, we take a lot of time to help all these patients that need help during their treatment in Kolkata. So we use social media. So Facebook is used mostly to raise awareness on for the urban population who are literate. But we have also online services for asking questions. So instead of getting to the oncologist, they ask the questions to the Cancer Society office, and then the questions are forwarded to us, and then we give the answers and advise further treatment or whatever is needed. And then we have this WeChat group. It is a great help for the rural people. So a patient wants to come from Eastern Bhutan to Thimphu for treatment or follow-up. So they get in touch with the Bhutan Cancer Society staff, who will then find out whether this service is there or whether the oncologists are in place or when to come and where to come. So everything is done by our Cancer Society staff and helped so that they get the services. So at the end, we hold World Cancer Day every 4th February, and in the memory of the lost souls, patients lost to cancer, we offer butter lamps, and all the people who are involved in cancer care, including oncologists, nurses, the Cancer Society, the palliative care team, and the survivors, all of us get together on that day and celebrate World Cancer Day. Thank you.
So we will have 10 minutes of panel discussion, and we will be opening our floor for questions for both online and physical. So we have touched on the Bhutan's experience, on their limitation with their geography and superstitions. We understand that innovation is here, the future is here, but not evenly distributed. Innovation may not be also tech and applications. I'd like to pose a question to the industry experts here. In what way could the industry be helping Bhutan with its geographic limitations and its superstitions, as well as its not technology-based, perhaps social media efforts in a way to advance the cancer care in Bhutan?
Maybe I'll go first. Thank you so much. It was a very inspiring presentation and a deeper understanding of how diverse our region is. We have a very highly evolved countries like Singapore, Japan, with advanced healthcare systems, and then we have other countries like Bhutan, which are getting started, and I think some of the work which is being done there is truly inspirational. I think just going on that example of using technologies like WeChat, and I think the pandemic has driven us to adopt digital in a more broader and in a more holistic way. And I think that could be something which we could potentially optimize. The one way where we have seen benefit is sometimes connecting countries who have the same pain areas or possibly a best practice to learn from each other. Because though we are very diverse, there are also commonalities that we can pick on and maybe just customize the solution. Potentially, I can see some of those coming for supporting patients in Bhutan. And the role of the industry could potentially be making this connection, driving this engagement, to be, in a sense, the aggregator when it comes together. I think we've learned that we're not technology partners, but we can definitely look at making those connections because we all are present in multiple countries with affiliates in most of our regions. So that potentially popped out as the first thing, is just optimizing the great work they've started on WeChat in terms of engaging with patients in rural parts of Bhutan, connecting them with information which is authentic, relevant, and validated. I think it's really important because there's a lot of unvalidated information which is going around. So I think we have a role which we could play in that space.
Yes, it's very interesting how Bhutan created that initiative. And I'd like to address on a little bit more on the diversity and access of technology. Of course, we understand that not all people have access to technology. How do you think your industry can contribute into that aspect?
Yeah, thank you for the question. So, firstly, thanks for the presentation. I really enjoyed that. I'm also responsible for Laos and Myanmar, Cambodia. In fact, when I was watching the presentation, I was thinking quite a little bit about Laos, and Laos has similar challenges. And I told my wife, I said, I could give all of Roche medicines to Laos for free, and it wouldn't improve outcomes. And the reason for that is because health literacy is low, and they don't have access to basic diagnostics. They don't have human capital. They don't have pathologists. They don't have enough oncologists. They don't have radiotherapy machines. So there are some basic fundamentals that don't exist that need to exist. And one of the things I would suggest is that we've worked closely with the Universal International Cancer Confederation, the World Bank. Recently in Cambodia, Phnom Penh is being designated as a city cancer tomorrow. And I'd encourage with having a strong civil society and a great patient organization, I would encourage Thimphu to actually, try to help register to become a city cancer tomorrow, because then, you essentially get resources to help you do a real needs analysis, understand where the gaps in certain cancers are, where cancer care is, and build a protocol, a policy document for government to listen to. And actually then Asian Development Bank, World Bank, they'll start taking more recognition when they understand what the needs are and where money needs to be spent. So I think that there are many things that I would encourage Bhutan to do and try and do differently. But yeah, as industry, I think we need to start with basics in countries like Bhutan, help with great health, improve health literacy, screening, prevention, diagnostics, before we even start thinking about treatment.
Indeed, indeed. We've heard also a while ago that Thailand's model could be also one of the reference that Bhutan is after. And I'd like to pose a question to Dr. Arshiya and Kawaldip. In the post-pandemic situation, where do you think the investment of health be prioritized? And do you think should be leading the charge towards patient-centered healthcare?
During the pandemic in Bhutan, we did not leave any of our health services out, except the OPDs were closed, the emergency services were open, and indoor services were open. And of course, the palliative care, people could not move, so the home-based palliative care was closed. So we were flooded with cancer patients in the hospital. So for the transfer of patients, Bhutan Cancer Society, along with Red Cross Society, they played a great role in bringing the patients in for their chemotherapy, for their surgery. And of course, we continued sending patients that needed radiation or other services to India through special flights. So the services, cancer services were not that much disrupted, except for in my town where there is home-based palliative care. The palliative care team could not go to the patients' houses. So that was the big problem. The other problem was for the dying patients, we used to, if we knew that our cancer patient is about to die and they were from outside Thimphu, we used to again arrange vehicles for them to go back to their houses. So changing so many vehicles along the way, we used to make sure that patients went home, met their relatives and died, instead of dying alone in Thimphu where no one can go to their funerals. So the other thing is we have HPV vaccination since 2010, and I was worried that this might be disrupted. But along with other EPI, other immunizations, so none of these were disrupted. So mother and child hospital was always open. So women who came for antenatal care, they could come to the clinics. Two of us ops gynae people were on call every day to give online treatment and permission for the patients to travel to the hospital. So these services were not disrupted, and the HPV vaccination of girls, class 6 girls, they get 2 doses of HPV vaccine in 6 months apart. So these were also not disrupted. So I was very glad. In fact, the Ministry of Health managed to introduce even vaccine for the boys 9 to 13 years in 2020. I think the MSD, the Merck, donated some nonavalent vaccines, and now we have started vaccinating the boys also. So thank you.
Okay, I think my answer to this question was very clear. Who should drive this? We have been told that health is a political choice, and this political choice takes place in competing interests. The 3 components of this is, firstly, the patient community themselves. The whole of patient community should be the main driver. And then, as in Bhutan, I think with the health minister, Honorable Disham Wangmo, who has really led it with the political commitment to it. We need the whole of the political leadership involved in this. And lastly, I think this is a matter of concern for the whole of society. The whole of society should be working with whole of government in investing in this. This is what we call the moonshot moment for us. In 1960s, when President Kennedy said that I need to go to the moon, people were saying, why? And then he said, the reason is that we got to do this for the betterment of everybody else. The spin-offs that will happen for other diseases will be enormous. This is an opportunity for us to now invest in this as a society, as a global community, and put your money into this, and let's go forward, and you'll see the benefits reaping. If we don't do it, we're going to be in the same situation that we were before the pandemic. We'll be struggling to get technologies out and having health systems that are inefficient and almost ineffective. So let's move now to make effective and efficient systems to this. The whole of patient community will lead it. So thank you.
Thank you very much, Kawaldip. And indeed, it's a moonshot moment for all of us. And I would like to take this opportunity. I think there's a question with the audience. The mic is available. You're within reach, and please seize the day.
Yeah. Hi, my name is Nidhi. I'm from Singapore. And I have a couple of questions. One is for Bhutan. It's quite scary to hear a lot of cancers being detected in the rural areas. I'm just wondering if somebody is looking into trends. Have they been rising recently? Especially, I'm interested in the upper GI. Is it because of the diet or any causes that have been identified? And then I have a second question, which is for Arshiya, regarding the vaccine for cancers, because we're talking about personalized care. And is this vaccine for a specific type of cancer? Because that was not mentioned. So if you could elaborate. Thank you.
So thank you for the question. In Bhutan, we don't know the reason, but I find that our population is less than 1 million, around 700,000, and we get over 600 new cases every year because I look after the cancer registry. So the most common cancers are actually related to infection, stomach, liver, cervix, then of course then lifestyle related cancers are also coming up like colorectal and breast and all these. So actually at present we have not looked at the causes. So we need to do a study on why stomach cancer is so high. So I think in the world we are fifth after Japan, Korea, China, Mongolia and all. So something to with our genetics or something to do with the type of Helicobacter infection we have. So we have high Helicobacter infection, but it is lower than India and Bangladesh, but we have very high cancer. So 15% of stomach cancer, 15% of total cancers are stomach cancer, and 1/4 of the cancer deaths are related to stomach cancer. So regarding the cervix, is due to our reproductive factor. Like in the past, the girls married very young and produced children at very young age, and many children. So with the change in economy, we hope that the cancer, and of course we have the strong screening program. So in the past we had pap smear, now we have shifted to HPV testing, since most of the girls now are vaccinated against the HPV. So regarding the head and neck cancer, it may be related to our lifestyles. So we are yet to do studies on why the cancer is rising in Bhutan. Thank you.
Nidhi, just to quickly, I know we're on time. This is currently being studied with pembrolizumab, which is Keytruda, for melanoma. A phase 2 study is being done, and the investigative product is mRNA 4157 V950. I had to learn that up. So more to come on that. We're in phase 2 studies right now, but this has been an ongoing commitment with Moderna, which started in 2016, way before the pandemic. So more to come on that. Thank you.
Just to add on the next session we will have is a very interactive session. Save your questions for that. It's about breast cancer, it's about other issues. So we'll be engaging you all totally and we'll be polling you. The team from Roche will be helping me out on that. So save your questions, get it ready. And thank you for coming with questions. This is about you. The talking is done now. We've done all the talking. Over to you.
And with that, thank you, Kawaldip. Thank you, panelists. And thank you for joining our Plenary 1 session, Asia Pacific and Personalized Medicine, Predictive, Preventive, Participatory, Personalized, and Pre-emptive, 5 Ps health systems in Asia Pacific. Thank you very much.